Assalamu alaikum, good morning. Today we will discuss Pyrexia of unknown origin, commonly known as PUO. So, Pyrexia of unknown origin definition: fever more than 38 degrees centigrade or 101 degree Fahrenheit on several occasions, duration more than 3 weeks, and no diagnosis after appropriate initial evaluation. It is called as Pyrexia of unknown origin. Pyrexia of unknown origin fall into five groups, that is I, M, C, and D. The mnemonic is IMCD, that is infection and inflammation, M for malignancy, C for connective tissue disorder, and D for drugs and miscellaneous. So, a syndromic approach helps to narrow the differentials by clustering the fever with dominant clinical patterns rather than the memorizing long list. So, now the syndromic approach to pyrexia of unknown origin. The first syndrome is fever with weight loss or night sweats. When fever is associated with significant weight loss or night sweat, think of chronic systemic illness. It includes infection, that is tuberculosis, HIV, and occult abscess, malignancy, that is lymphoma, leukemia, or any solid tumor, and lastly, infective endocarditis, the subacute bacterial endocarditis. The clinical clues are cachexia, lymphadenopathy, and splenomegaly. The targeted tests are CBC, chest X-ray, CT chest or abdomen, blood culture, HIV, and TB workup. If patient presents with fever with lymphadenopathy, in case of pyrexia of unknown origin, lymphadenopathy is a very important clue. The common causes are tuberculosis, lymphoma, HIV, SLE, and Kikuchi disease. The key step is early lymph node biopsy can be diagnostic and should not be delayed. But before lymph node biopsy, CBC with PVF is mandatory to exclude leukemia. If patient presents with fever and rash, rash narrows the differential significantly. Think of adult onset steel disease, vasculitis, drug induced fever, and any viral infection. The clinical clues are evanescent salmon color rash, arthalgia, high spiking fever, and the suggested investigations are ferritin, ANA, ANCA, and eosinophil count. When patients with fever with arthalgia or myalgia, fever is associated with joint pain or muscle pain, then the common causes are vasculitis, that is polyarteritis nodosa, giant cell arteritis, connective tissue disease, that is SLE, rheumatoid arthritis, and steel disease. The initial investigations are SR, ESR, CRP, ANA, rheumatoid factor, ANCA, and CPK. Fever with hepatosplenomegaly. This combination suggests hematological or systemic infections. Common causes are the hematological malignancy, it may be leukemia, lymphoma, visceral leishmaniasis, that is Kala-Azar, chronic infection, that is tuberculosis, and hemophagocytic lymphohistiocytosis. The initial investigations are CVC with PVF, ferritin, and bone marrow study. Fever with neurological features. If pyrexia of unknown origin is associated with fever, confusion, seizure, and any focal deficit, so think of tuberculous meningitis, any brain abscess, autoimmunoencephalitis, and CNS vasculitis. The investigations are MRI and of brain and CSF analysis. Fever with cardiac murmur. Always think of infective endocarditis. The changing murmur, embolic phenomenon, and splenomegaly are the initial clues of infective endocarditis. Investigations are three sets of blood culture and transesophageal echocardiography. Fever with normal examinations. This often is the most frustrating group. The possible causes are drug fever, factitious fever, early malignancy, or autoimmune disease. So, in this case, detailed drug history, observe fever pattern, and repeated physical examination is mandatory. What are the baseline investigations for PUO? Before advanced testing, every PO patient should have CBC with peripheral smear, ESR and CRP, liver function test and renal function test, blood and urine culture, chest X-ray and ultrasound of the abdomen. The key principles in PUO. Repeated history and examination are the crucial part in case of PUO. Avoid empirical antibiotics and steroids. Tissue diagnosis often gives the answer. This is all for today. Thank you. Thank you very much.